Welcome back to The Short Code, coming to you from the amazing and intense world of medical school at the University of Iowa Carver College of Medicine. I'm Dave Etler, and we're back talking about one of the ways that doctors get paid with Dr. Nathan Flacker of ChenMed, a group of practices dedicated to preventive medicine for low and middle income seniors using the capitated payment model in which insurers pay the provider a monthly flat fee for all the patient's care. Welcome once again, Dr. Flacker.
Good to be here. Thank you for the invitation. And
don't forget my medical student co-hosts. How very dare you? First up, it's MD PhD. First up,
second time.
It's MD PhD student Riley Behan-Bush.
Hi, Ron.
M2 Zach Grissom is here.
It's still weird when you say M2.
I know.
And it'll change every year.
M3 Alex Nigg returns.
Hey.
Why aren't you in clinic?
I took a little vacation. Don't tell them.
And M4 Jeff Goddard is back too.
Hello.
As we've discussed, Dr. Flacker, you work with geriatric patients at ChenMed in a practice that's paid a flat amount to maintain a patient's health and prevent illness. I think we all would like to hear sort of how that plays out on the daily and how that looks different, sort of on the ground for you.
I do my best to describe that. So if I'm a provider, okay, in our practice, on a typical day, you come in. There is, for our center, we have a whole center huddle every morning. So this kind of gets everybody's staff online, issues that came up the day before, corporate initiatives, and we measure stuff. So we go over center metrics. Our metrics, so in a fee-for-service practice, you might be reviewing your RVUs. In ours, we're reviewing hospitalization rates and hospital arrivals. And so that's the stuff that matters to us. Well, we have a system for being pinged if one of our patients hits an emergency room the night before or is admitted the night before. So we come in the morning, we know who's been admitted or been to the emergency room. And so we review who those are and who's going to follow up with them. We then have a care team huddle. Sorry. So you meet with your care team, sort of go over your schedule for the day. Here's an example of a high-intensity primary care model. So if you have a patient under normal fee-for-service who has whatever trouble, shoulder pain, back pain, headache, whatever they walked in for, first of all, we'll see them. At some practices, we'll just tell you to go to an urgent care. Some practices accept walk-ins. We don't accept walk-ins. We celebrate walk-ins. We want people to come see us, right? We actually don't even call them walk-ins. We typically refer to them as patients in need. Like some of this is about mindset related to patients. And to be successful in our practice, you have to have a somewhat different mindset. So part of our routine process would be if somebody came in as a patient in need a day or two before, we've called them to see if they're doing better. It's not call us back if you're not doing better. We're reaching out to be sure people are getting better. We have patients we've identified as our higher risk patients for a variety of reasons. And there are people we see every 2 weeks instead every 4 weeks as our standard. And on the week that we're not seeing them, we call them to see how they're doing. We call them love calls in our practice. Okay, so we do a love call on the off week. How you doing? Go over things. So those kind of things, those love calls, if there were issues, are reviewed as part of that huddle to determine, if the PCP, if the provider needs to reach out to those patients or somebody on the care team. Then you start seeing people. Once a week in our clinic, we have an all provider meeting, which is about people who have been hospitalized and lessons learned from that. I'm going to say something that we say around here that everybody knows isn't true. But again, it's about mindset, which is that we try to look at things as that every hospital admission is a failure of outpatient management, which doesn't really mean it was a failure. It just but if you come at it with the perspective of, okay, this person ended up in the hospital, let's dig deep and see, maybe it's, it's very often not even the quote unquote provider's fault. If you're going to try and assign fault, we don't really try to assign fault. We try and figure out our systems, but maybe the patient had an appointment, canceled the appointment. We didn't get them rescheduled for whatever reason. So we have to then go look at our rescheduling system and see how that miss happened. So we review those hospital arrivals. And then there's another meeting once a week, which is with the entire clinic, about our highest risk patients and what we're actively doing that week to prevent them from getting sicker. Whether it's connecting with a social service, like there's a whole variety of reasons somebody might be a high risk patient, and what interventions we can do to prevent that. So, as I say, in our practice, the visits are 20 minutes for follow-ups. The documentation requirements under value-based care are much less than under fee-for-service, so we can be really efficient. And so when you've been in our practice for a while, again, from a provider perspective, it's very possible to see the patient, complete your note, have it closed before you move on to the next patient. And that's what we work very hard with. People who have come out of residency training, very often other practices, just write too much stuff, but get uncomfortable when you try to make them write less stuff. Because since, your very earliest medical school days when, you have your 80-year-old patient that you're starting out with the APGAR score on, like this is all this stuff, it's just not relevant, right? So we document what needs to be documented so you can actually complete your visits, do all your stuff, and answer your messages, because there's workflow that's usually screened by somebody on your care team. You have a care team, so you've got we call them a care promoter. So that's a one-to-one. You can think of as your MA with your right-hand person in clinic all the time. You've got a scheduler who is managing your schedule. You've got, we call a care coordinator. So they're doing your referrals and your diagnostic tracking. And so the doctor isn't out there alone, but we do expect the doctor or the nurse practitioner, we have nurse practitioners in our practice, as the leader of the care team. And so they're coordinating the activity. It's very possible to come in, do your job, and when you're done, you have worked very hard at a fulfilling job, but you can go home and not have, in prior places of employment I've been, what's called pajama time. If you go and interview in a practice, ask what their pajama time is, and I may not even need to define that term for you to be able to figure out what it means.
Yeah, well, I think we got it. The amount of time you spend at home doing documentation, calling patients, whatever. Yeah,
but it's because of our organizational mission. It's not easy, right? You might think, okay, normally you have 2,000 patients, you only have 450 patients. That's got to be like a cushy job. We're seeing our people more frequently.
Yeah.
If you think about unusual practice, in a usual practice, like if you look at the oldest third and the sickest third of the oldest third, that's like our average patient. Okay, so it is hard work. So you do have to have that love of seniors and love of primary care. But if you have that, then it's super fulfilling. Like I make people's lives better every day. That's kind of a nice thing to feel, and better in a real tangible way. So
do
Jeff,
you
are you
feel
going to
say, let's say 450, do you feel like that's kind of the cap for the panel that you could maintain well at this moment?
Yeah, I think the sweet spot is between 400 and 450. As I say, there are other practices that do it different, don't see the patients as frequently, so they can manage higher panels. You could, in theory, do this with a doctor and nurse practitioners. Our nurse practitioners in our practice are not quote unquote physician extenders. They're independent. They independently manage their own practices. We have really, really good nurse practitioners in our practice.
So I did some back of the envelope math here, and I want your thoughts on this.
Sure.
Okay, so just so you understand where I'm coming from. I don't know why we're not, I love the fact that ChinMed has been able to scale so well from, one practice in Florida to now in 12 different states or something like that.
Yeah.
I don't know why more people aren't doing this, but I love to see that it's scaling in any way. I would love to see this national for, all different kinds of people. But there are about 340 million people in the United States. There are about currently 1 million doctors in the United States. I think we're a little bit north of that, but we'll round, we're ballparking here. which, by the way, that's the highest ratio we've ever had. There are more doctors per capita today than there ever have been in the history of this country. If 75% of current doctors were doing this primary care model, their panel population would be about 450. In most countries in the world, about 70 to 75% of their doctors are primary care. In our country, it's about 30 to 35%. So like this right now, like, again, I'm not going to convince every doctor in the country nor every politician in the country tomorrow to switch this model, but like it is feasible.
We'll see. The show hasn't come out yet, Jeff.
maybe they'll all jump on board. But like the point is that like the numbers are already there that we could do this. And like you're working with the most important population, I think, the population where we're going to be making the most, in the short term, the most significant difference, right? Like you take a 5-year-old who's in a relatively healthy home and, you know, upper middle class, like, you know, I've got a 9-year-old, he's got 2 parents that are going to be doctors. He's kind of fine. I don't know that he needs to be significant. But that said, like this model is already something that could be scaled to the entire nation successfully without increasing the patient panel any more than what you think is already feasible with just the doctors. I'm not even pulling in the MPs or the PAs. Do you think it's just political capital, or do you think it's just like cultural momentum that keeps us from being able to reasonably scale this model out to other populations that can benefit from it?
Okay, so before I answer this question, I should probably add the disclaimer that this is about to be my opinion and not necessarily represent the opinions of ChenMed or any of its ownership or you know, important people there. So, wow, good question. And I haven't done that math that way before, so that's really neat to hear that we actually could do it feasibly if we had the desire. So a couple of things. So one is an issue that you all are familiar with, which is the tremendous amount of medical school debt. So you might want to be idealistic, but when you graduate medical school, like how are you actually going to pay that back? And there's significant salary differential between different specialties in primary care, right? I think that people, there's also a certain cachet to being a specialist that people are attracted to, which I think pulls folks into that. I think also the training environment, being pretty much everybody's being trained in an academic medical center. You have high contact with academics and academic specialists. And so people at the medical school level aren't really seeing primary care in the way that they're seeing specialty medicine. And even, and no knock against primary care practice in academic settings, but it's different than community-based primary care. And,
yeah, you're talking about exposure to different ways of doing things, which
I think that we also, now getting into some of the nitty-gritty, the way that we pay for medical education. So I don't know why we're paying, and my cardiology friends will now be mad at me. I don't know why we're giving so much graduate medical education money to cardiologists when we've got like lots of cardiologists. We may not have them in the right places. Different other discussion, how you incentivize people to go to rural communities, right? But there's, and the other data is very clear. If you want to improve the health of a community, you don't drop 100 cardiologists there. You drop 100 primary care docs there. Right? That data is clear. We've known it for a long time. So in a lot of ways, I really got to scratch my head about the politics of this, because if you try to take an objective look at it, like lots of primary care and health-based outcomes is a great way for us to improve health and save money in the country. So if you're a fiscal conservative, why you would not be all over this, I don't know. Except that we have a tradition in this country, and we equate lots of specialty care and fancy gizmos and proton beam facilities and and all for robotic surgery and all that other stuff. But I did the math, which I won't remember off the top of my head. But $400 million, I will just say, will buy you a lot of social workers. And who's good, and what's the differential in terms of outcomes and improvement in health and happiness of a community of a proton beam facility, which will help some people, no doubt, or a couple of thousand social workers being able to really dive deep into the people that need their assistance, which probably was more of a soapbox complaint than actually answering your question now that I reflect on it. But
I think it's fair because I think I am going into the surest path to the upper class of American society, right? I'm going to be a physician. Physicians make up the vast majority of the top 10% of income earners in this country. We're wealthy class, and that's a great privilege. We try to give back to the community with our service and all that stuff. So I'm not trying to denigrate doctors for making money, but at the same time, there is no doubt in my mind that barring unforeseen catastrophe, I've got a real shot at 90, and probably beyond that. We're pushing the margins on the wealthy, but I feel like there's just more quality life years to be had with those that are on the other end of the spectrum, the populations that you're working with. And it's not like you're proving it. Like it's not necessarily that it's easy, but it is simple,
And again, you get this differential if you look across states between rural communities and urban settings, but even in urban settings. So most of our clinics are in cities, to be fair. I'm sitting here in Atlanta in a what would be considered a poor demographic zip code. I can drive 3 miles north, and my life expectancy goes up by 15 years. That's just for redistributing how we're giving care and access to it is a real untapped potential in this country, and generating more specialists concentrated in small medical centers in wealthy communities is probably not going to change that very much.
When I feel like that's part of where it goes back to like medical education and just the system as a whole, because there is such a push to specialize and do research and do all of these fancy fellowships. And, if you want to be at an academic center, like you're going to have to do some sort of research, and you really have to find your niche, because there aren't a lot of people anymore who do it all. And back in the day, I mean, if you were to have like a family medicine provider, they did do all of these things, and they saw their patients in the hospital, and they did take a lot more care of all aspects of an individual, versus now, again, the system is just not set up that way. And I think that primary care is undervalued in medical education, and it's almost like, I don't know if this is maybe just me internalizing things, but like there's like an aura of, like if you're going to family medicine, that's the easy way out. Like you're not going to do something that requires a fellowship and extra years of training. It's probably because you're not smart enough to do that. Whereas like that is absolutely not the case. Everyone has their reasons for going into different things, but I do feel like there's like an attitude that makes people resistant into wanting to do primary care things.
Well, my own anecdote, like as I was building out my schedule, I'm interested in internal medicine or OB-GYN. And I remember telling someone who was, whether they realized it or not, they were like, oh, wow, you're interested in anything primary care. That's interesting coming from like an MD, PhD. And I was like, whoa, like who's to say I wouldn't also be interested in preventive medicine? And I didn't even tell you if I was interested in a subspecialty, but it was like this understanding of like, oh, why would you do that if you would also then go into primary care medicine? And so it's like that anecdotal slight
and even like
against it,
things getting more and more owned by specialists, because like I have a big interest in emergency medicine even already as a M2, and like you hear that more and more things get kind of turfed, or like procedures that when I've shadowed they were like, yeah, we used to like do this, and now they don't want you to even do it. Not that there's like a difference necessarily that they can point to for an evidence-based reason for not doing this or that procedure at the bedside in the ED versus
this is mine now.
Yeah, versus it's like now owned by bringing a specialist either to come do it, or you're just going to, be a transfer center. You're barely a resuscitationist as that person. You're just the referral to get them air cared from tiny little rural county in Iowa to Iowa healthcare instead. So
yeah, it's pervasive. I interview graduating primary care, family medicine residents in some programs. I ask them what what kind of procedures they can do, can't do. And so not trained to, I do joint injections all the time, right? Not even trained to do joint injections because at their place, all the joint injections went to sports medicine.
Mm-hmm.
And so they didn't have the opportunity to learn, they're smart enough to do it, and I could teach them to do it. I do. But the training is so segmentalized that now we have primary care trained doctors who aren't comfortable doing primary care stuff because they haven't been able. All the people with diabetes go to endocrinology, and all the people with a heart go to cardiology, and all like. I mean,
At that point, it's like, what are we doing?
right, and because in a to be super cynical about it, in a outpatient primary care practice, right, you are a loss leader, right? The health system tolerates you because you get people in the term loss leader, right? So you'll probably figure out what that means too, right? So they're willing to lose some money on you because you bring people in who you can refer then to people who they can make money on. In a fee-for-service system, specialists and proceduralists are responsible for probably about 95% of the revenue, right? And primary care is, if you're doing really well, you're kind of breaking even, and so you're tolerant. And so how important are you to the healthcare system, right? If you switch to a value-based model where keeping people out of the hospital and keeping them healthy is important, now suddenly primary care is super important because you're about 80 to 85% of the revenue. So even from a primary care importance and prestige point of view, it flips the script on how healthcare operates and how healthcare is incentivized from different specialties. I mean, we'll do a thought experiment, okay? Here you are, University of Iowa, great place. Like, you must have been super great college students because it's, it's a great place to go to medical school, right?
Yeah, we like it.
Yeah, so you go out there and you check in with all the family medicine people and all the internal medicine people, and those people are so great at their jobs that nobody is ever hospitalized. How happy is your healthcare system?
Probably not very.
Probably not very. And that's a fundamental tension that you get in healthcare systems under a fee-for-service arrangement.
Frankly, that was a really good place to end.
Yeah.
It's a really good line to
I
end
think
on.
the thumbnail
That's a
should
good
be
mic drop.
a rotisserie chicken from Costco for the loss leader there. Is that in the thumbnail? I just had
getting people
I
in
had
the
to get that
door.
on tape so that you'd remember when you're going back and editing.
I'll think, yes, very good. Shortcoats, if you have something you'd like to say about today's show, something you want to hear about today, question you have, go to theshortcoat.com/tell us and send us a message. Otherwise, thank you so much for talking with us about capitated payment systems and the way that you do health care at ChenMed, Dr. Nathan Flacker. Hope to see you again someday.
Happy to come back. It's great to see the future of medicine in front of me there.
Yeah. Otherwise, that's our show. Until next time, I'm Dave Etler saying don't let the bastards get you down. Say bye, everyone.
Bye.
Thank you.